I don't know if you guys can see all of it. It looks like part of the
We're officially recording, Mary, so I just want to let
Okay.
you know.
That's cool. Do you want to say who I am and what I'm doing, or?
Sure, I can,
Want
or
Go
Clarice
for
can,
it.
whatever works.
Well, from what I know about Mary, she's our presenter tonight. She holds probably about 10 different roles in MOTA currently, and probably at least 30 over the past few years. She's a home health occupational therapist, and she's going to talk to us about falls. Mary's been instrumental in helping shape MOTA and with getting us licensed in the state of Missouri, as well as helping out with Hill Day and all of our other initiatives. So she very graciously agreed to do this presentation this evening. So I will let Mary take it away in a second here, but I did want to announce to everyone I've tried something different with how we're doing certificates. So I did go ahead and post the quiz in the chat box. The quiz link is also posted on the website right below where the Zoom link was.
Okay.
Your certificate should be emailed to you as soon as you submit the quiz. So even if you don't score an 8 out of 10, which I'm still working on, but please, honesty system, if you don't receive an 8 out of 10, just retake the quiz and resubmit, because really we want to make sure that you're demonstrating competency. So if you have an issue, just email me at the MOTA Practice Gmail, but hopefully your certificate will be sent to whatever email you plug into the form. Sound good? Great. All righty. Well, Mary, I will let you take it away.
Hot diggity. Well, I've been doing home health for like the last 10, 11 plus years. And I have a passion for fall prevention and home safety because it is something that's really important for all of the home health practitioners and people that work in other adult settings. So the objectives tonight are just to describe some of the terminology used in studying balance and mobility, identify some major age-related changes that affect balance and mobility, identify some of the risk factors associated with increased falls, and recognize some assessments and training techniques to identify fall risk and try and do something about it, identify some treatment considerations and strategies, and describe how occupational therapists can assist in fall prevention. This is the primary resource that I used. Her name is Dr. Deborah Rose. I actually bought the first edition. This is the second one of Fall Proof. And she is the professor and a chair of kinesiology department at California State University, Fullerton. She's also co-director of a Center for Successful Aging at California State University in Fullerton and Fall Prevention Center of Excellence. And that was started in 2005. The original edition, I think, was printed in 2003. But I found this is the primary resource that I used, and it is primarily looking at older adults in home health because that's what I know. Fall prevention and assessing fall risk is very important for supporting older adults to age in place, and OT can play a very significant role in that. So terminology, balance and mobility, and these are Dr. Rose's definitions, but center of mass, it's the same thing as center of gravity. It's the point at which all of the mass of the body is concentrated when analyzing the force that acts on the body and the body's motion. Balance is a process by which we control the body's center of mass with respect to the base of support, whether it's stationary or moving. And posture definition is from Shumway Cook Woolacott. And that's also a good resource too, but they're all listed at the end in the bibliography. Posture refers to the biomechanical alignment of the individual body parts and also the orientation of the body to the environment. And base of support, none of these should be a surprise as far as the definitions. refers to the area beneath an object or person that includes every point of contact that the object or person makes with the supporting surface. One of the things that I did notice as far as base of support, I've seen a lot of folks in home health that can't get out of bed, but once they're up and moving, they can walk pretty well. And I finally figured out that one of the reasons is because when you're lying in bed, the base of support is so large that a lot of these folks cannot overcome that. And it took me quite a few years to figure that out, you know, that they can't get out of bed by themselves, but they can certainly get up and walk around. And it was because of that reason. Stability limits is the maximum distance an individual is willing or able to lean in any given direction without changing the base of support. And I always measure functional reach test or a modified functional reach. Functional reach is just standing and exactly what it said, their limit as far as how far they can reach. And it has a direct, functional reach has a direct correlation to fall risk. So it's something that I use quite a bit. Sway envelope was kind of a new term for me, and it's the path of the body's movement during a standing balance activity. And mobility, it's simply the ability to move and safely from one place to another. Anticipatory postural control was a little bit of a new thought process for me, and it's advanced planning of actions. And then the reactive postural control is actions that cannot be planned in advance due to the unexpected nature of the event. These are some examples, and hopefully you can see all of them left to right. The first one is an ankle strategy, and I'm going to go into more depth with that. The second one is a hip strategy, and the third one is a step strategy. And these are all postural control strategies that are used for trying to control balance. And that was reprinted from Dr. Rose's book. So definitions for postural control strategies to maintain balance. Ankle strategy is when the body moves in as a single entity about the ankle joint, where the upper body and the lower body sway in the same direction. The hip strategy is when the upper body and the lower body move in an opposite direction as a result of the hip muscles being activated to control balance. So your butt might stick out, but your head goes in the other direction. And then the step strategy occurs when the center of gravity is displaced beyond the maximal stability limits or sway, and it's too great for the hip strategy effectively to be used. So this requires a new base of support to be established, and that's when that third picture where she had to take a step. So requirements for effective balance strategy, and again, this is Dr. Rose's information. The ankle strategy requires good range of motion, strength at the ankle joints, a firm, fairly broad surface below the feet, and an adequate level of sensation in the feet and ankles. And there's a lot of chronic problems that older adults have that inhibit this ability. I mean, people who, for instance, have diabetes and even just idiopathic peripheral neuropathy can cause a lot of problems with this. They can't feel their feet that well, or even their ankles. So then the hip strategy requires adequate range of motion and strength in the hip region. And then the step strategy requires adequate lower body muscle strength, power, and range of motion, and adequate central processing speed, which is kind of like the person's ability to react to things in the environment and make a move, and then the ability to move the limb rapidly during that step initiation. So there's a lot of different systems, multiple systems that contribute to balance. And some of them, or most of the important ones, are listed. So sensory systems, and that's just to anticipate changes affecting the action and the response that already occurred. And those would be like vision, hearing, touch, taste, smell. Vision is one of the most important to have for good balance. People do not seem to realize how much they use their vision to maintain balance. And Stephanie Stegman went over some of this when she did her the previous month in June on vision. So the motor system then acts on internal and external sensory information. The muscle response is synergistic, and that is just groups of muscles that work together producing a movement. And it can be involving the central and peripheral nervous systems that support that movement. Somatosensory system provides information about our spatial location and the movement of the body relative to supporting surfaces, and that's obtained through mechanoreceptors, chemoreceptors in the skin, epithelial tissue, muscles, bones, joints, organs, and CVS is cerebral vascular system. And vestibular is also important too. It works in conjunction with the visual system, and it determines whether or not we are moving or the world is moving. And that's located in the inner ear and provides balance and spatial orientation for coordinated movement. Last but not least is the cognitive system, which produces, it is also needed for the process. So process such as attention, memory, intelligence, abstract reasoning, problem solving, and spatial abilities, etc. So considerations for regarding age-related systems. These are just kind of some information that we need to be aware of. Older adults have to allocate more attention or cognition to maintaining good balance. Changes in the body systems contributing to balance and mobility are inevitable consequence of aging. So as we age, we have decreased vision, decreased muscle strength, our vestibular system can age, and then there's the effects of chronic diseases and polypharmacy on our bodies, which all can have an effect on balance. Optimal motor function is achieved through the interaction of multiple internal and some external systems. And then age-related changes, again, in vision, the visual system, can adversely affect older adults and their ability to accurately perceive or anticipate changes in different surface conditions, or even the presence of hazards in the environment. And again, Mary Warren spoke to that, and Stephanie is going through that specialty certification in vision, because vision is one of the most important things. It takes us the deepest into our environment and also helps us anticipate obstacles or problems. And it's really super important. People do not realize how much their visual system affects their safety and fall prevention. So the vestibular system is also critical for balance when the sensory information is absent. For instance, if somebody's blind, that's very difficult. Or if the information is distorted or conflicted, where from visual or somatosensory systems don't match. And that's what the next definition is. Sensory conflict can occur when information by one or more sensory system doesn't agree with other ones. Fast facts on system changes and aging. It's depressing. Between the ages of 50 and 70, muscle strength can decrease as much as 30%, which was a tough pill to swallow. Since I'm between the ages of 50 and 70, but at least 10% of all people, and this is also tough too, 10% of all people over 65 years of age and 50% of those over 80 years of age have some form of cognitive impairment. And it can range from mild deficits to dementia. And so that can definitely affect your balance and ability to maintain good mobility. There is growing evidence, though, that we can reverse or at least slow some of the rate of the decline occurring in some or all of these systems, and studies on both healthy and older adults who with existing balance problems have demonstrated some moderate to large improvements in balance and mobility and a reduction in falls through Dr. Rose's program. interventions that target the sources of the balance-related problems, and then repeatedly exposing those older adults to changing tasks and the demands are particularly effective. And I guess the best way to sum that up is just saying that learning for adults happens in context, which is something that we learn from our training. And it's very, very true. And I'm lucky enough to work in home health where in context, I get to work with people where they have to live and to function. And so that's one of the best environments to do some of the training. So there's multiple factors that can cause falls. The intrinsic ones, they can be age or disease related changes occurring within an adult or an older adult. And these are the clinical manifestations that the OT and OTA practitioners can identify through some routine screening and evaluation processes. And we have to realize that we can't necessarily fix the problems, but we can help someone compensate or adapt the environment to make them safer. So the deficits can include deficits may include sustained activities, endurance, vision problems, bowel and bladder issues, cardiac, lung issues, and we could go on and on. There's all kinds of chronic problems and medical problems that can cause problems. And also polypharmacy, medication and interactions. I think, and that's what the next slide deals with, I feel that polypharmacy is an area that occupational therapists don't get a huge background in as far as our education and training, but there are some applications on smartphones that we can use to try and look up some of these drugs. These are just some that are listed to check for that could cause problems with balance and so forth. And they're listed there for you. I'm not going to go into them, but I have looked up formulary and non-formulary names of drugs on a phone app that I use, and it's listed in the resources slide, and it's called drugs.com. And I used that one and it worked out pretty well. So if I need to look up something that I'm not sure about, I can look it up in the client's home using the smartphone. But I'm sure that there are some other apps, I'm just not as familiar with them, but the drugs.com is the one that I use. Extrinsic factors for consideration by OTs would include most of the bulk of what I end up looking at. There are a lot of external factors that can elevate the risk for falls during the performance of any ADL activities. And as OTs and OTAs, we should make changes or adaptations to the community dwelling older adults environment if we can to make them safer. At least 1/3 to 1/2 of all falls sustained by community dwelling older adults can be attributed to external factors. And we're going to go into them more extensively in subsequent slides. We are the experts, though, on basic and instrumental activities of daily living, and including the application of assistive technology. And some of those are listed below. Assistive technology is not a term that I used so much to describe adaptive equipment or durable medical, but that is the terminology that they use now. So the use of bathroom durable medical equipment would include things like toilet risers, shower seats, tub benches, handheld shower hose, grab bars, and all of those can help improve safety and functional mobility for these clients. Adaptive devices, the smaller dollar ticket items would be like sock aid, long-handled reachers, shoe horns, toilet aids, etc., and they can all help prevent falls. These are some of the external factors that are associated with falls, and these are all things that I look at when I'm going into a client's home. So ground surfaces, and it's mostly, we say ground surfaces, I'm talking about in the home in most cases. So rugs, loose flooring, slippery, wet floors, electrical cords that are all across the walking space, oxygen tubing, and managing that is a huge problem that I find with a lot of clients, especially the ones that I see who are on oxygen that have COPD or congestive heart failure. Polished floors, stairs that are in poor repair, narrow pathways for ambulation devices, and walkway clutter can be a problem. Furniture, unstable or low seat surfaces. I usually always measure the client's heel to the back of their knee crease, the length, and that gives me a biomarker that I can use to recommend optimal height for any number of things, whether it's the bed, the toilet, the favorite easy chair that they sit on. So furniture is a huge problem, and we're going to go into, I have 2 handouts that I give to all my clients, and that will again be on subsequent slides, but it deals with furniture and some of the other issues that are in this slide. So you want to make sure that they're using beds that aren't too high or too low, or cabinets that are too high or too low. And we can always help them adapt with that. The lighting, that is something that Stephanie also covered in the low vision. So glare from any uncovered windows, lamps, dim lighting can be a problem. Absence of night lights, for night toileting can be a fall risk. And also in the bathroom, toilets that are too low. I mean, unfortunately, standardized toilets are not standard. In some of the homes that I go into, the homes are new, they're old. The toilet height can be from the floor to the sitting surface can be anywhere from 12 inches, which is almost like pediatric school bathroom height, to 14.5 to the comfort height, which is considered 17.5 to 18 inches. So the height of the toilet is something that I always look at. They may not have grab bars. They may not have any non-skid surfaces getting in and out of the shower. They may not have anything to sit on to take a shower, which if someone's balance is bad, you always want them to sit whenever they're using one or both hands. And then the handheld shower hoses I find very useful. But I find a lot of times that clients that I see at home will end up taking a towel and just throwing that on the floor and using that when they get out of the shower. And it's really not a good thing. It doesn't really, it's usually kind of slippery. And I always try and recommend that they have some kind of a non-slip surface when they're getting in and out of the shower. So, and I check the height. If they do have durable medical equipment, I make sure that after I've measured that heel to the back of the knee crease, that I check, because optimal height for most normal adults is going to be somewhere around 18 to 22 inches. I find that most adults that I measured, and it doesn't matter how tall or how short you are, the lower leg dimension is always going to be usually somewhere between 16 and 18 inches. So that the optimal height for most normal adults to sit on is going to be 18 to 22 inches. And you want to make sure that when they sit on the toilet that their feet hit the floor, they're flat on the floor. I've had some folks who their family were really trying to be nice, and they ended up getting a toilet riser that had the rails on it, and really all they needed were the rails, because the height of the toilet from floor to the sitting surface was already comfort height. And then if you add, some of those toilet risers can be anywhere from 3.25 to like 5.25 inches. And then you've lifted them up so much, which they didn't need the height, they just needed the rails. And you can get just the toilet rails, but then their feet are dangling, and it's very difficult to empty your bowels or bladder when your feet are dangling on the floor. I mean, I don't know about you all, but it's a lot more comfortable and it's safer to have your feet, at least the ball of your foot, if not the whole foot, flat on the floor when you're trying to empty your bowels and bladder. So enough about bathroom. But outdoor environmental hazards, ground surfaces, I mean, those are usually irregular. You have sloping sidewalks, wet leaves, ice, snow. Oh, and that should be on the walkways. Rocks, anything, grassy areas that are holes that are not visible, and everybody has divots in their yard. So you want to be careful. And usually physical therapy will address most of the outdoor hazards, to be honest. I don't always get them to go outside unless for some reason they need to be able to get out to get their mail. Because some folks have their mailboxes attached to the house itself, and others it's out at the street. It depends on the age of the subdivision and the house itself. Homes with home access, when you have like no handrails on the entrances, either from the front door or the garage, stairs could be in poor repair. They have raised thresholds, or stairs that are too high where the riser goes above 7 inches, or you even have some where the treads on some of the basement steps and even getting into the house, where the tread, which is the flat part that you step on, that is too short to fit your entire foot on it. And that makes people uncomfortable. If your foot is not on entirely covered by the supporting surface, then it could be a problem. And then out in the community, if you have people, traffic lights that don't allow enough time for someone who moves kind of slow to cross the street sufficiently, or even some of the parking spaces, who hasn't gone to a parking lot, where the parking spaces are so close together that the doors aren't able to open fully, and that makes it difficult to get out because the space that you have to slither in and out is pretty narrow. Or even uneven surfaces where you have an incline or a decline on the walking surface, and those can also be a problem. Other hazards, poorly maintained walking aids or improper shoes or socks. And that's one of my pet peeves, is improper shoes or socks. And I'll get into that later. But even with the walking aids, I am not a big fan of the rollators, just because I have a feeling that a lot of people that I see don't have the cognitive wherewithal to make sure that they lock the brakes. And if they don't lock the brakes, then sometimes the seats are too high for them to sit on and their feet don't hit the floor, where someone was nice and gave them or bought them a rollator, but the seat surface is not that great. And those wheels, it has people kind of leaning forward and trailing behind them. I'm not a big fan of the rollators, because they're better for transporting items from one area to another, but they're not necessarily good for anterior support because there's 4 wheels instead of 2. This is the first part of one of the handouts that I give to everybody, all the clients that I see, and the ones that are highlighted, and I think they're backwards. The next slide is actually the first part. This is the second part, but the most important things that I go over are the ones that are highlighted. And good fitting footwear is your best friend. There's 4 features to a good fitting shoe, and that is, you want to make sure that you have good traction, footbed support. The vamp of the shoe, which is like the toe box to where it stops on the top of your foot, should be long enough that it keeps your foot over the traction and the footbed support. And then you have to have some kind of a heel cup or heel counter to make sure that your heel doesn't roll or rock off of the back of the shoe. And I'm not opposed. Flip-flops are an absolute no-no for people who have really bad balance. But, and a decent tennis shoe is probably going to be a good thing, but not everybody can wear something that has to be laced or tied. And then you can go into the whole assistive devices or adaptive equipment for, trying to make a slip-on shoe out of a tie shoe. And that's a whole nother issue. But you definitely need a shoe that's going to be snug and that it has even a narrow heel cup. Even like some of the Birkenstock sandals, I'm not opposed to those, especially if the strapping comes up high enough, because they do eventually mold to your footbed. But a lot of the folks that I see are not wearing shoes because they can't fit them on their foot. And so they have a lot of swelling or edema and they can't wear their shoes. And so they end up wearing those god awful treaded socks that they give you at the hospitals. And those things, it gives you a false sense of security. Yes, it has some traction, but eventually that launders off. And it is a sock after all, and your foot can still slide around inside of there. It provides no arch support, and the traction that it does give you is kind of not good enough. So I'm not going to go over all of those things. The other thing that's emphasized is I usually recommend that people don't sit on the edge of the bed. If you sit on the edge of the bed, if they lean forward to try and put any lower body clothing on, it can allow them to kind of scoot off the soft side of the bed, and that's not a good thing. This is actually the first part of the handout. And, you know, throw rugs, area rugs, that was one of the other things. And then I talked a little bit about the sitting surface heights. Ideal thing for somebody, normal sitting surface heights is 18 to 22 inches for most normal adults, depending on the length of their lower leg. And so there are things that you can do to either raise or lower the height of a chair, but you want to choose a chair that is stationary and it has armrests if possible. A lot of people love those swivel rocker recliners, and with a rocker, you always have to scoot to the front edge of whatever you're going to be getting up from. And if you scoot to the front edge, it dips down to about 12 or 14 inches. And that is wicked bad to try and get up from. So you want to make sure ideal chairs for people to sit on are like the dining room chairs that are the captain's ones that have the armrest. But even if you don't have an armrest, most of the dinette chairs measure about 18 inches, and that's the crown of the cushion. So it's a good height for most normal adults to get up from. And I will take one of those sometimes and put it into somebody's bedroom and let them sit on that to try and get dressed, because sitting on the edge of the bed, if they have room, there are times where you go into somebody's house and they have so much furniture crowded into the room that they cannot necessarily do that. They can't get another thing in that room. And in that case, they'll have to grab their clothes and hopefully maybe go someplace else to get dressed. So that's the fall prevention. The other, and I do these handouts front to back. The fall prevention strategies is something that is the most important. But then I also have just some basic home safety strategies. And there's a lot of things listed here. The first one is adequate lighting, and Stephanie already addressed that. And this is also the basic home safety strategies continued. This part with the fire safety and burn prevention is most important for people who are using oxygen. I mean, unfortunately, I've had some folks that were on oxygen and were still actively smoking. They would at least take the nasal cannula out, but you know, it was still laying around, and it's pretty daunting when they do that, but you do as much as you can as far as safety prevention. I do believe in giving people handouts. You can tell them all you want, but unless they have something to refer to, and I usually take a highlighter and exactly what I highlighted or was highlighted on the previous fall prevention, that's what I do, is I'll highlight it for them, talk about those things, and give them the handout so that they can refer to it later. And then some of this is just common sense. Personal safety. Keep your doors locked at all times. Keep a telephone within reach in case you do have a fall. You want to make sure that you're able to get a hold of somebody. And I usually will have a conversation with someone who's a high risk for falls. I will talk to them about getting some kind of personal protective emergency call system, like the Lifeline, Philips. There's so many companies out there now that have those little wristlets or a pendant they can wear around their neck. And most of the pendants are actually waterproof, so that you want to make sure that you take them into the shower with you, because that is important. Okay, switching gears. we're going to go to some suggested tests and evaluations. And what I did here is give you the ones that I use the most. The Barthel, and there's a modified Barthel. There's two actually. One of them, the Barthel Index, the one that I use is a 20-point system. The modified Barthel Index, or the Shaw, they were both, I think, revised in 1988. That one has 100 points, but they both are self-reported basic ADL tools. And I use this as part of the interview where it's a culmination of what I see and the answers that they give me, but they all seem to go over bowel, bladder function, grooming, or I think the Shaw version calls it personal hygiene, toilet use, feeding, transfers, like from chair to bed, mobility, which in the Shaw version is called ambulation, dressing, stairs, and the Shaw version says climbing, and then bathing setup. So I write myself some notes, and I've gotten used to talking to them about durable medical equipment. So on the form, I actually have a paper copy and I'm filling this out, and then I use that. These particular tests are not particularly sensitive enough that they're going to show a lot of improvement. And the way things have been going with the change in reimbursement, especially for Medicare as of January 1st of this year, I don't get a whole lot of visits with these folks. So I try and make sure that I give them as much information as I can on my initial evaluation. If they are someone who does the instrumental activities of daily living, I use the Lawton. And again, it's a self-reported tool that includes questions on their ability to use the phone, shopping, grocery shopping, who does the food or meal preparation, housekeeping, laundry, mode of transportation. And usually under mode of transportation, I'm asking them if they still have a valid driver's license. I've been very surprised sometimes that some of the folks that I see, and they're like, oh yeah, of course I have a valid driver's license. And you're like, oh my God. But I'll ask them if they know when the expiration date is, and just to kind of get a feel for whether they're still driving or if that's a goal for them, because sometimes the mode of transportation, they're able to get in and out of a public transportation like a metro bus or whatever, or a relative's car. But I also want to know if they plan on driving in the future. That can be an issue. Who's responsible for their medications, and last but not least, their ability to manage household finances, and who's doing that. A lot of times you find out who the power of attorney or POA is for someone, because that's usually they have offloaded that task to a son or a daughter or someone else. The fall risk factors checklist is one of, there's some really good handouts that are available from the CDC and STEADY website, and that's part of the resources page. I gave you guys links to that. But it asks about fall history, medical conditions, medications, gait, strength, balance, vision, postural hypotension, and other risk factors. And it's a form that the CDC, and it's free. So if you go to the link, you can download lots of different forms. Now the functional reach, I mentioned that earlier under the base of support slide. The modified functional reach is done sitting. The functional reach test is done standing. You administer it either way. If it's sitting, it's modified. I usually bring a tape measure and just do it that way. I'm not about to take a yardstick and tape it to a wall and have them do that, because a lot of times there isn't any open wall space to do that with. So what I usually do is just measure the forward progression of the middle knuckle on the dominant arm with their feet and their feet shoulder width apart, and using that tape measure, or you can use a yardstick. But I have a tape measure that I take with me, and that's really a tool that I use for like I said, measuring the heel to the knee crease, the length of their lower leg. And then I also use the tape measure for the modified or the functional reach. If they've got a death grip on their walker with both hands, you know that functional reach test standing is going to be 0. So I usually end up at this point, because it does have a correlation, and I gave you the test information and how to interpret it here on the slide. So I usually try and find out, and may have to have a conversation with them or a family member about how they transport items from their kitchen. Usually if they're grabbing a sandwich or something like that, and they're using a two-handed ambulation device, whether it's a rollator or front-wheeled walker, I usually make some inquiries as to what they need to do for carrying things from one place to another. And you always want to make sure that these folks are going to stay hydrated. And so it's difficult for them to like go get even one of those lidded pitchers that you get. If you're trying to hang on to that and a walker at the same time, it usually is bad. I always usually end up also asking, and I don't know that I mentioned it previously, but I do always ask during the Barthel index or the modified Barthel, I always ask about night toileting and their sleeping habits, because it's really important for you to make sure that they're getting a good night's sleep. If they're getting up a zillion times to go to the bathroom, that's going to be a fall risk as well. And one of the things with the Lawton too, the first thing that most people give up is how long has it been since they changed their bedding and washed it and the sheets, because that is one of the first things that people give up when it comes to housekeeping. It's one of the most difficult housekeeping tasks to do, and you'll find out they haven't changed their sheets since who knows when. And that's not a good thing. It's one of the most difficult IADL tasks to do. There's a few more tests I was going to go over, evaluations that are used, and most of these are from the cdc.gov study. The timed up and go is available. It's free, and it's for mobility assessment. They should be wearing regular footwear and a walking aid. If they need, that would be a cane, a walker, whatever they use. And then you start from a standard armchair and you identify 10 feet. I'll use, in some facilities, I've used a trash can, I've used a orange cone that I keep in the back of the car. And that's another reason to have the tape measure, to make sure that you can measure that. But you have to have the space. 10 feet can be quite a bit uncluttered or unfettered space if you're trying to do it in a home. So it just depends. But anybody who's equal to or less than 12 seconds to complete that is at risk for falls. So if it's equal to or less than 12 seconds, over 12 seconds, I'm sorry, I read that wrong. Equal to or greater than 12 seconds. So if they're really slow and it takes them that long to complete it for like one loop from the chair, you time them from the time that they stand up, go 10 feet out and back, and then sit back down. And if it's more than 12 seconds or equal to that, it's not good. They're fall risk. Then there's the 4-stage balance test, and there are 4 standing foot positions. And essentially it's kind of increasing in difficulty. So at first you have them stand in the positions that you start with, is feet together, and then you have them staggered where you have half of the foot, and then tandem, which is heel to toe. And then you actually, if they do all that, great, then you can try and have them stand on one foot, but they have to try and hold it for 10 seconds. You can use your arms to move, but you can't move your feet for this one. And these are all part of that website, and that one's also listed. And then there's the 30-second chair stand. This is to test leg strength and endurance, and you can use a straight back chair without armrests. It has to be at least 17 inches high, and you want to perform this and do as many sit to stand sequences as you can possible in a 30-second period. most of us are familiar with the timed up and go. I'm not sure how many folks, but like I said, the 4-stage balance test is interesting too, because it also kind of ups the degree of difficulty. So treatment handouts and considerations, I tried to give you guys, one of the websites that I use a lot is the OSU, which is the Ohio State University patient education pages. And I have given you also the link for that. You put in some keywords, and if you put in these, their Move Big is for disorders like Parkinson's patients. The Save Energy, this one is a really good one on energy conservation and work simplification. If I have somebody who is at home by themselves and their balance is not that great, I will encourage them to sit to do anything. And I mentioned that previously, that if their balance is really bad, then I want them to sit to bathe. I want them to sit, if they can, to wash their face, brush their teeth, shave. I want them to sit in the kitchen whenever they're using one or both hands. If you know that their functional reach is really poor, then you want to make sure that they're sitting whenever they have to use one or both hands, because otherwise it's dicey. You just don't know. The chair stand exercise is one that is with the CDC, but most of the rest of these are from OSU, which is, it's the Ohio State University, or Wexner, WEXNER, medical system, which is part of or associated with OSU. So just to summarize, and we'll get to some questions if you have any, occupational therapists are very well positioned, I think, to prevent falls through assessment tools, education on safety, chronic disease issues, and use of assistive technology or adaptive devices. I do want OTs to be very mindful always of the potential visual deficits and some sensory losses, because we may be the only discipline that looks at that. I'm not really sure in my practice how many of the physical therapists or speech therapists, which is more rare in home health, but I have had maybe a couple of clients in any given year that are seen by speech, and I really don't know how mindful those therapy disciplines are of potential visual deficits. And I've already talked to you about how important it is to have that. As clinicians, we're responsible for improving client habits and basic and/or advanced ADLs. And I think it's important that we do that in order to allow clients to try and age in place safely. So OTs and OTAs need to advocate for the consumers within our agencies and our external community partners, which would be like Areas on Aging, Society for the Blind and Visually Impaired, Meals and Wheels, and the VA. I have had experience with all of those agencies, and those are just examples. I mean, there are probably other ones out there, but what I'm trying to do is to advocate for the clients and help get them more assistance, support, if I can, from those different agencies to keep them so that they can age in place. But I want them to do it safely. To consult with other team members like family members, private duty caregivers, that's what the CG is, nurses, social workers, PTs, doctors, any government agencies, to try and advocate and ensure that the clients are well positioned and supported in their homes. And in the interest of being transparent, I rarely do get to keep a client long enough to see some of the treatments or exercises that I've given to them pay off. They have to be motivated in home health to kind of follow through and do for themselves without a whole lot of oversight, unless they have a caregiver or a spouse. And whenever I can, I always involve the caregivers, private duty folks, or the spouses in some of the exercises and that, because they can help them. I want to make sure before I leave and close out the episode or that client, that they're able to do whatever the handouts that I gave them, to give some return demonstration to make sure that they understand or at least the caregiver or spouse understands how to do them correctly and why it's important. But the object of home health is, I think, to teach clients how to manage their return or manage their chronic problems going forward, because the home health reimbursement has really limited me to fewer and fewer visits. So I pretty much get to give them the tools that they need to get better or stay at home and out of the hospital without necessarily being able to see the payoff. And a lot of times I will consult with the physical therapist. They love, love, love to give exercises. And so they pretty much are the ones that do the follow-up for balance. One of the physical therapists that I work with has almost as many years of experience as I do. And he always works on balance. That's kind of his thing. And so I make sure that I confer with him whenever it's appropriate to try and work on some of the core. I can work on core exercises and he'll work on some of the dynamic balance. I'm more concerned with static balance because that's what they need to stand at the closet and get their clothes out, stand at the sink to brush their teeth, wash their face. So that's kind of the division of labor where I do more concerns with ADL item retrieval and replacement with static balance versus the dynamic component, which I leave to physical therapy. Questions? And I'm going to go through their resources and then the bibliography. Ta-da.
Mary, that was great.
Are you still awake?
Yes.
Anybody? Oh, Claire DePrimo's here.
I was
Yay.
wondering, do you ever do like fall recovery training with patients where you actually have them get on the ground and get back up? And because I made the mistake of doing that with a recent amputee as a new grad, and that was a bad call. But how do you normally do this kinds of sessions?
Well, you know, at home, I have not been able to do that as much, but I have done it at, because I've worked in acute rehab, and you throw a mat on the floor, you lower them to the floor, and then you try and teach them the best way to get up, like pulling themselves up to a mat or a chair or something. But yes, I have, and I've written goals for floor to mat or floor to chair transfers, because you're right, it does happen. And we can't necessarily keep them from falling, but we can certainly teach them how to get up. I don't know if anybody else has, curious what I think about, missed it. What I think about the market for the OT's role in aging in place consultation outside of an insurance payment model. Ooh, there's a good one. I am working with a current new grad that is working in an Affinia federally qualified health clinic. It's a very non-traditional model. I'm not really sure how the payment is going, but I do think that some of the balance programs have happened in community centers, in non-traditional settings. I think the market is good for that, but I'm not really sure what the payment source is going to be. And I think sometimes we have to think outside of the box. There are different, like, diagnostic related categories like Alzheimer's Association, MS Society, Parkinson's disease had the American Parkinson's Disease Association had a chapter here in St. Louis. There's a physical therapist in my particular area in South County who's doing that Rockstar, where they're doing like the boxing to help improve balance for Parkinson's patients. And she's getting paid for it as an outpatient clinic. So I think the potential for it is there, but you have to have a good support system who's going to be able to get you to do that, because no one is going to pay me to go into somebody's home and do that week after week after week. So I see the potential, Tracy, more as an outpatient thing or a community center class of like folks that have like interests and balance issues. But the Fall Proof book that I referred to is one of the best resources that I've seen. This book is really good, and it has lots and lots of different activities in there. And I like that it was written by a kinesiology person. You know, she's not listed as an OT or a PT or whatever. She is a professor of kinesiology, and she's fabulous. And the whole book, the last few chapters, give you all kinds of suggestions of different types of strategies. They use Swiss balls, they use all kinds of things, but I don't get to keep people long enough to make that leap. It's one of those things where they may have to pay out of pocket, but they're going to have to want to.
And I think the Medicare Part B world in the home is growing quite a bit.
You betcha.
And that's been a place, because I've got a couple friends who do Med B in the home, so outpatient billing, and they do a lot of the fall safety and caregiver training. And that's kind of something too with the home modifications. And that's something where we've been trying to do a lot of education that if you're doing functional evaluations and fall safety, that can't necessarily be a cash-based service if it's a Medicare patient, because Medicare will cover Medicare Part B if it's in the home, which I think I'd really like to see more home health agencies get certified to do Med B in the home as well, which I think would allow for therapists to follow through.
Well, the agency that I work for, we're subcontractors, so we have contracts with lots of different places. It's a lot of paperwork. Most of us should, if we don't, have an NPI number, which is a National Providers Identification Number. As an individual, Medicare doctors have had them for a long time, and I've had one for over 10 years now, but that is a requirement for Part B, so there are some things that we need to be able to do in order to be a Part B provider. It's a lot more complicated as far as the billing, and a lot of the agencies I'm finding want us to be the experts on picking the CPT codes and everything. And I think hopefully if anybody here is available, they should watch Cindy, because it's a good segue to, she's going to be doing next month, August 6th, I believe. So I'm doing a commercial for Cindy. But, you know, I'm going to be there too, because the Med B part, I'm very familiar with Part A, but I'm not as familiar with Part B. And it's really super important that I educate myself. And actually AOTA had something pretty good not too long ago too. It was a webinar that might still be available as a recorded.
This is Wendy. I just want to mention too that I think with the state of Missouri, and maybe Cindy will be addressing this, that like outpatient, you can't just go into people's home unless you are a home health agency. You can go and do a home eval, and they don't even like all three services, OT, PT, and speech, to go in. They prefer one, but sometimes they'll overlook. So to go in on regular, that the state of Missouri allows it. So, but that's something maybe Cindy will cover.
Hopefully she will.
Yeah, that would be interesting, because I'm not sure why Missouri would have different Medicare laws than other states.
Well, it's under the Department of Health and Senior Services, and that's just how the state of Missouri have their regulations written. So states can vary. It's not federal, so that's one thing I would just caution people on until we know for sure about that.
Well, I'm telling people too to make sure that they vote August 4th, because the Medicaid expansion is August 4th. Good old Mike Parsons moved it from April to August. And I think they hope it fails, but I'm got my fingers crossed that people will wake up, smell the coffee, and vote for it.
That's
because-
statewide. So whether
I
or not
know.
you've got a primary or not, make sure
Yep.
you get out and vote on August 4th. It's number 2, initiative 2 on the ballot.
Agree. So I think it's important that we be responsible. It's advocating for our clients, our consumers.
All right.
So we really should.
And also for us, the more people who have health
Yep.
insurance, the more people who have access to OT.
Amen.
So, but yeah, thank you, Mary, and you did a great job segueing into Cindy's
Yep.
session. So next month,
Just
Cindy
throw money.
is returning. She did our telehealth seminar, if you watched that. So she'll be presenting on Medicare Part B billing basics. So she's going to kind of cover CPT codes and what they are, the KX modifier, kind of the basics of what you should know if you're billing Medicare Part B, which I think it's important for anyone who's going to be doing Part B in the home, working in outpatient, even in acute care. We bill Part B when our patients are observation status. So it's going to be a good foundational course that sometimes we don't always get in school, or if it's been a while since you've been in school, CPT codes have changed. So
Absolutely. And they're bound to change again.
So if anyone has any final questions, let us know. Otherwise, everyone have a great 4th of July.
Oh yeah. Thank you. You all too.
Yeah, same to you.
Thanks. You too.
Okay. Until next time. Thank you all.
All right,
Thanks,
take
Mayor.
care.
Very good.
Bye, everyone.
Bye.